Assalamu alaikum. I am Dr. Syeda Farzana Yesmin, Associate Professor, Gynae Obst at Akij Medical College, Khulna. Today our discussion will be continued about the investigations of recurrent miscarriage. Proper diagnosis of recurrent miscarriage. Cause of recurrent miscarriage need a thorough history taking, meticulous clinical examination and associated investigations. For diagnosis, the careful history taking should include the nature of previous abortion process and histology of placenta, karyotyping of the abortus if present. Also, any chronic illness. The diagnostic tests includes routine blood examinations, which includes blood grouping, Rh typing, complete blood count, random blood sugar, HbSAg, VDRL, also torch screening for any genital tract infection. Then among others, hormone assay to exclude hyperthyroidism. To exclude these hormone endocrine abnormality, we should do serum TSH level as a screening test for thyroid abnormality, luteinizing hormone on day 2 or day 3 of the cycle. We also do autoimmune screening to detect any autoimmune disease, which includes anti-nuclear antibody, anti-DNA double-stranded antibody, anti-phospholipid antibody, anti-cardiolipin antibody, lupus anticoagulant. These investigations are done to exclude any autoimmune disorders. Then we do ultrasonography. Ultrasonography help us to detect fibroid of uterus, congenital abnormality of uterus, any ovarian abnormality or pathology, polycystic ovaries such as polycystic ovaries. Then we go for hysterosalpingography. Hysterosalpingography help us to detect any cervical incompetence, any feeling defect which may include fibroid, Asherman syndrome, uterine synecdoche, and also any tubal block. This is supported, these two, ultrasonography and hysterosalpingography is supported by hysteroscopy or laparoscopy, and if possible karyotyping of both partner, husband and wife. Endocervical swab to detect any genital tract infection like chlamydia, mycoplasma, bacterial vaginosis. Now treatment. Investigations complete, we can reach to a diagnosis which is the cause of this type of recurrent miscarriage. Then we should treat according to cause. Now treatment includes treatment in the interconceptional period and treatment during pregnancy. During interconceptional period, to alleviate, proper counseling is necessary. Proper counseling of wife mainly is necessary to alleviate anxiety and to improve psychology. We can counsel the couple and we can assure them that pregnancy outcome is possible after even 3 miscarriage, 75% possibility of a pregnancy after even 3 consecutive miscarriages. The success rate of pregnancy outcome depends on mainly on the age of the wife Also the etiology of recurrent miscarriage. And if the cause is due to uterine anomaly such as Synechi septum, uterine septum, Synechi, or due to fibroid or cervical polyp, we can do hysteroscopic resection. Hysteroscopic resection does help us. With a hysteroscopic resection, we can give treatment of septa, Synechi, submucous fibroid, which improves pregnancy outcome. Also, uterine unification operation, metroplasty, can be done in case of bicornuate uterus. Uterine unification operation or metroplasty is possible in case of bicornuate uterus with hysteroscopy. If a chromosomal abnormality is detected in the couple or in the abortus, genetic counseling is undertaken. In such a case, if possible, karyotyping of the products of conception from future miscarriage is mandatory. Couples with chromosomal translocations or inversion is counseled for pre-implantation genetic diagnosis, that is prenatal diagnosis by chorionic villus sampling, amniocentesis in subsequent pregnancy, or in case of pregnancy with donor gametes, sperm or oocyte. Women with PCOS are treated for their insulin resistance, hyperinsulinemia, hyperandrogenemia, and metformin therapy is helpful in such a case. Very much helpful, metformin therapy in polycystic ovarian syndrome. Any endocrine abnormality like diabetes mellitus, hypothyroidism should be treated properly. When definite cause is not found, but there is subclinical hypothyroidism or mild variety of diabetes mellitus, then we should treat to improve the fertility. Subclinical hypothyroidism and diabetes mellitus. In case of genital tract infection, we should do endocervical swab or vagina swab and do culture sensitivity, gram staining. We can give empirical treatment with capsule doxycycline or erythromycin, as it is cost effective. During pregnancy, reassurance and tender loving care can remove the stress of the woman and improves uterine blood flow to the fetus and improves the pregnancy outcome. So, reassurance during pregnancy, reassurance and tender loving care is very essential. And then we should give her advice for proper rest. Bed rest may be necessary. Rest of the patient should take adequate rest and should avoid strenuous activities, intercourse, journey in this period. We can give progesterone therapy, especially in case of luteal phase defect or in case of recurrent miscarriage. We can give natural micronized progesterone. Natural micronized progesterone 100 mg capsule may be given per vagina or per oral natural micronized progesterone 100 mg twice daily may be given. The treatment usually started 2 days after ovulation and continued for 10 to 12 weeks. But if necessary, to support the pregnancy, progesterone can be given up to 32 weeks, and it has immunomodulatory role for successful implantation, continuation of pregnancy. This natural micronized progesterone helps very much. Due to its immunomodulatory role, it induces pregnancy protective shift to an anti-inflammatory cytokine response. In case of anti-phospholipid antibody syndrome, women are treated with low dose aspirin, usually 50 to 75 milligram daily given, or with heparin 5000 unit subcutaneous twice daily may be given. We also use unfractionated heparin, low molecular heparin in such a case. This heparin therapy may be continued up to 34 weeks. In case of recurrent miscarriage due to cervical incompetence, we do circlage operation. This circlage operation includes Shirodkar suture, McDonald suture, and we must know details about this Shirodkar suture and McDonald suture. In case of chromosomal abnormality which can be diagnosed by chorionic villus sampling or amniocentesis, or pre-implantation genetic diagnosis is possible in blastomere stage. Pre-implantation genetic diagnosis is possible in chromosomal abnormality in blastomere stage. If diagnosed, we can only transfer balanced embryos within the uterus, and a successful pregnancy is possible. Immunotherapy, we can give paternal cell immunization, third party donor leukocytes, trophoblast membranes, corticosteroids. In case of inherited thrombophilia, we give also heparin, and this anti-thrombotic therapy of heparin improves pregnancy outcome. In such a case, heparin 5000 unit twice daily subcutaneous may be given. Also, low molecular weight heparin, enoxaparin subcutaneous once daily can be given, and this heparin is very much effective, also continued for 34 weeks in case of inherited thrombophilia. If any medical complications present, then we should diagnose it, and the couple is advised to treat the medical complication first, then the wife should be pregnant. Such type of medical disorders includes hemoglobinopathies, cyanotic congenital heart disease, diabetes mellitus, hypertension, SLE. This type of medical disorders should be treated first, then the woman should be pregnant. In some cases, the cause remains unclear and unexplained. Despite different investigations, 40 to 60% recurrent miscarriages remain unexplained. However, tender loving care and supportive therapy improves the pregnancy outcome about 70%. In next class, we will know about circlage operation in cervical incompetence. Thanks a lot.